This is charming. I hope that some of our colleagues will continue to join us. I introduced myself to Professor Ferguson at the Provost and Academic Senate's joint retreat this fall, and which I attended on behalf of the Retired Faculty Association. And Laura spoke, and I thought to myself, good gracious, this lady knows something about inequalities in global health of which I am totally ignorant. So I dashed up and whispered in her ear that I would love to sponsor her on an RFA distinguished lecture. And she was very gracious and agreed to do so virtually on the spot, right, Laura? And
you're very convincing, Jerry.
and so, you know, I followed very closely on the American news, American television news and newspapers, the COVID epidemic, and listened to most of the White House press briefings on COVID pandemic. And I realized that I knew virtually nothing about the rest of the world and how much there might have been shared distribution or vaccine hoarding by the developed countries that developed the vaccine and had access to it. And so I was hoping that we could all learn something more from the most recent pandemic and perhaps also the HIV pandemic that preceded it. Laura Ferguson is at the USC, well, she's the director of research, I believe, at USC's Institute on Inequalities in Global Health. So I thought she might be the lady to help us understand this better. She is an associate professor of population and public health sciences in the Keck School of Medicine. And she's director of the program on global health and human rights and director of research at the Institute on Inequality in Global Health. Laura comes to us with a Master of Science in Population and International Health from Harvard and a PhD from London School of Hygiene and Tropical Medicine. And she and I have found that we have in common some experience in a low-income country named Kenya. And Laura spent extended periods of time in sub-Saharan Africa and collaborated with local governments and partners to help manage research and programs to tackle a broad range of issues, including HIV and AIDS and sexual and reproductive health, and child health. And she advises the World Health Organization and UN AIDS. So Laura, I'll turn it over to you.
Thank you so much, Jerry, for that very kind introduction. And thank you for the invitation to be here. I'm thrilled to be able to talk to you about some of these issues and share some of the work that we're doing. So I am going to, I hope, share my screen. There you go. And yeah, just talk to you a little bit about pandemics, politics, and people. I'll give you a little overview here of what I plan to cover, and I'm going to try and keep an eye on the time so that we have time for questions at the end. But if anyone has questions for clarification as we go through, please just let me know. I'm totally fine with being interrupted. I teach undergraduates, so I'm quite used to it. So I want to talk about what global health inequalities are and why they matter. I then will give you a little information about the USC Institute on Inequalities in Global Health, and then really dive into two pandemics, HIV and COVID-19, to see what we've learned from them. And then hopefully have a little bit of time to talk about sexual and reproductive health, which is another area that I would put in the emergency category right now, and then try and wrap things up for you all. So first of all, I mean, are health inequalities real? I think we all know that the answer is yes, but I think it's also important that we just dig into what that looks like in a very real way. And if we start in this country, we know that Black and American Indian and Alaska Native women have pregnancy-related mortality rates that are about 3 and 2 times higher than the rates for white women in general, which obviously seems unacceptable. We also know that a woman's lifetime chance of dying due to pregnancy-related causes is 1 in 5,300 in high-income countries and only 1 in 49 in low-income countries, right? That's again, just not okay. And just one more example, people in low-income countries have an average life expectancy more than 18 years shorter than people in high-income countries, right? So we're not talking about small differences here. We're talking about really enormous differences across different populations, sometimes in different parts of the world, but sometimes in the same parts of the world. And what I want to point out is if we can bring down, for example, pregnancy-related mortality among white women, we can do it for all women. We just have to want to, right? We have to make it happen. And the same, if we can reduce this chance of dying in high-income countries, we can also do it in low-income countries. We just need to make it happen. So we need to sort of dig into what's underlying some of this. So in terms of why do health inequalities matter? I mean, I come at this from a human rights perspective. Everybody has the right to the highest attainable standard of health, right? Everybody is born equal. We all have the same rights. I think it's also a social justice issue, and we can come back to that in a bit. There's a more pragmatic argument that resonates with some people that our health is intertwined with that of everyone else. And I think COVID really brought that to light. But it goes beyond infectious diseases. We also know that there's a limited budget for health in the state, in the country, in the world. And so if other people are disproportionately sick, they're using up a disproportionate amount of those resources. Again, there's an economic argument there. We know that in more equitable countries, people live longer. They actually also have a range of other better health outcomes as well. And we know that inequality itself reduces social cohesion, and that leads to stress, fear, and insecurity. So there's a whole range of reasons, from, if you like, more idealistic to economic to health and social reasons why all of this matters. So where does it come from? And again, I think this is a really important piece of the puzzle that is often overlooked. Our health is not ahistorical, it is not apolitical. It is, in fact, history, politics, culture, these massive social forces that shape the distribution of wealth and health, both between and within countries. So we're really talking about social and structural determinants of health, these large-scale forces, whether they're history, whether it's politics, whether it's law, whether it's how health systems are structured or financed. All of these play into not only the health of individuals, but the health of different populations and the differences between those, right? And just to complicate things further, these factors operate from the global level right down to the local level. We see power asymmetries at all of these different levels, and we're all shaped by the environment at those different levels, from the global down to the very local. So if we can agree that health inequalities exist and they really matter and they're determined by some of these large-scale forces, we need to think then about what do we do about them. And so when It was in 2018, Sophia Gruskin, who's a senior colleague of mine, she's a professor in my department and now director of the Institute on Inequalities in Global Health. So in 2018, she took over what was then the Institute for Global Health at USC. And one of the first strategic decisions that we made was to rename the Institute and to bring the idea of inequalities into the name of the Institute, partly to differentiate us from the hundreds of other institutes for global health that exist around the world, but partly to really ground our whole institute in health and human rights and in this notion that inequalities in global health make so many other things worse. So it's not just about overall levels of health, but we really are concerned with those who are most disadvantaged, those who are being marginalized, those who are being left behind. Another key decision that we made at that point was that we wanted to be a pan-university institute. So previously the university had sat within the Department of Preventive Medicine. And for us, that wasn't enough. I think there was a huge recognition that to address the kinds of large-scale historical, political, legal, social forces that I've already talked about, we needed the strength of the whole university. And we needed to be able to tap into the intellect of faculty and students across the whole of USC. And so we very explicitly set ourselves up in that way. So now we sit in the Dean's office at Keck, but we are a university-wide center. And so this is our vision, which is to be a center of excellence in global health research, education, and policy engagement that takes a dynamic, interdisciplinary, and collaborative approach to addressing the health disparities and inequalities that impact our world, right? So we were very clear from the outset what it is that we wanted to achieve. And just to go into that in a little bit more detail, we set out that our mission was to work, again, with partners both across USC and around the world, looking at health-related disparities and inequalities and then this comes back to research, education, and policy engagement, expanding the evidence base around what works to advance global health, training the next generation of global health leaders, and effectively informing public policy. And, I can go into many ways in which we've approached this, but just to give a couple of examples, in terms of research, one of the multidisciplinary projects that we have is we found out that Microsoft was really interested in leveraging artificial intelligence for good. And so I reached out to someone at Viterbi, because I barely know what artificial intelligence is, but she does. And we together got funding to use artificial intelligence to better predict childhood malnutrition in Kenya. And neither of us could do that without the other one. And so it's just like a nice example of how the different parts of the university come together in very synergistic ways. In terms of education, we've done lots of things, lots of different courses where we bring in students from across different schools and have them working together. I'm not going to go into too much detail on that just for now. And then in terms of public policy, here's just a few examples of some of the ways in which the faculty within the Institute are engaging with policy. So you can see we're on advisory boards at the global, national, and city level. We're on various journal editorial boards, including AJPH, Global Public Health, Sexual and Reproductive Health Matters, and much, much more. So what we're really clear that we're not doing research for the sake of research, but that there is an impact that can be had from the kind of research that we've done, as long as we're engaging the right people. So last thing to say about the Institute is just our approach. And this feels really important to me because it's essentially the philosophy that underpins how we operate. And we don't always see this in global health, just to put that out there. Global health, particularly right now, is in a moment where everybody's talking about decolonization. Again, we're in a world of power asymmetries, where in the global north, we hold more power than our partners in the global south. And so we're really cognizant of that and doing what we can to balance it out through these equitable partnerships. All of our partnerships are long-term. Some of these people we've been working with for 20 years already. So there's huge trust and respect in how we work. We communicate very openly. We work across different sectors, and we're trying to grow some different synergies in our work. So that really feels like our foundation that we work from. So that's a little bit of background on us. Now let's talk about pandemics a little bit. And I'll talk a little bit about some of the lessons we've learned and also the roles that the Institute has played in this. So let's start with HIV. Everybody knows HIV is a retrovirus. It's affected the human population for over 40 years. But here's the good news. We can prevent HIV. We can prevent sexual transmission. We can prevent transmission from mother to child. We can prevent transmission between people who use drugs, and we can treat it. So we can't cure it, but we can treat it. And if people are adherent to treatment, their viral load becomes undetectable, which means they can't further transmit the virus and they can live a normal life themselves, right? So there's obviously, we've had 40 years of science to figure this out, but there's really positive news, I think, in the HIV world. But why then, last year, did we have 1.3 million new HIV infections in the world? And you can see from the map that approximately half of those occurred in Africa, right? So we know how to prevent this disease, and yet we're not succeeding. We also had over 600,000 people die from AIDS-related complications last year. We know how to treat HIV, so why are we still losing people at this rate? And again, you'll see that over half of them are happening in sub-Saharan Africa. So we're already seeing some inequalities floating to the surface here. Even if we look at the different parts of Africa, you can see that it's Eastern and Southern Africa that's most affected. We could drill these data down, not just to country level, but really to district level, and we'd see massive inequalities even within countries in terms of new infections and deaths from HIV. So again, we've got to ask ourselves why. And I want us to dig into that by looking first of all at who. So if you look at the middle pie chart here, which is sub-Saharan Africa, right? And we're looking at new infections, and this is slightly older data, but I couldn't find these pie charts for last year. We can see that 49% of new infections in Africa are among what's called here the remaining population. So people who are not sex workers, who do not inject drugs, who are not gay men or other men who have sex with men, who are not transgender women, and they're not clients of sex workers or sex partners of any of these other populations, right? We know that the vast majority of that 49% are adolescent girls and young women, right? So we have to then ask ourselves why. So we know we've got incredibly high infection rates in sub-Saharan Africa overall, and that most of this is happening amongst women and young girls. Now, there is some biological logic behind this. Young girls, their reproductive tract is not fully developed, so if they're engaging in sexual activity, they are at higher risk of acquiring HIV. But it goes far beyond the biological, right? And so this is a quick look at some of the social factors that affect HIV risk. So we can see here the disproportionate number of new infections in African young women. We also know that women who've experienced violence are 1.5 times more likely to acquire HIV than those who have not. We know that women with less education are more likely to acquire HIV than those who have not. We know that almost half the women around the world can't exercise their right to make decisions as basic as whether or not to have children. So if you can't make that decision, you can't make a decision about who you're having sex with and under what conditions, right? So there's a whole power dynamic going on around gender that's very important here. We know that transactional sex is a real issue, and that's driven by poverty, and we have young girls engaging in sex for school fees or school uniforms or school books. And we know that female sex workers have a much higher risk of acquiring HIV than the general population. So while biology can explain some of what's going on, It's actually gender and social norms that explain far more about why women and girls are disproportionately affected by HIV in sub-Saharan Africa. And, you know, there's good and bad news in that. The bad news is we all know that societal norms are very entrenched. They're hard to change. But the good news is they're made by societies, and societies evolving. So if we choose to challenge them, and if we choose to change them, we can all work together to do that, right? So that was sub-Saharan Africa. Let's look at the rest of the world. In the rest of the world, only 6% of new infections are among that remaining population. So what we're saying is in the world outside of sub-Saharan Africa, 94% of new infections are among sex workers, people who inject drugs, gay men, other men who have sex with men, trans women, and clients of sex workers and sexual partners of these people. So again, we've got to understand why. Like, we've got very different HIV epidemics going on in different parts of the world, and if we want to do something about them, we need to understand why they look so different, right? Well, one thing that all of these groups have in common is that across many settings, their behaviors are criminalized, right? And we can see how law plays a huge role in affecting HIV risk among these populations. And these are just a few stats from 2020, where we see an enormous risk differential between these key populations and those who do not identify with those key populations in terms of acquiring HIV, right? So again, biology explains some of this. We know, for example, that unprotected anal sex is a higher risk activity in terms of HIV infection than vaginal sex is. But again, it's actually the social and legal factors that explain much more of this, right? If sex between men is criminalized and it's happening in public spaces, it's happening in a very hurried manner because nobody wants to get caught. And so people aren't thinking about protection, right? Just one example. And we can go into the pressures that female sex workers are under to not use condoms from some of their clients, and the lack of autonomy that they may have in those situations, right? So again, we're very much focusing on social and legal explanations for this disproportionate risk of infection. So I wanted to, like, in the spirit of interdisciplinarity, stick with the law for a minute and look at how law can be used as a tool within global health. And so first of all, it can be used to domesticate international human rights laws, so to bring international human rights commitments into national laws. And law is also used, as we know, to regulate societies and behaviors. And in 2012, there was a very high-level commission on HIV and the law, and they came out with some very strong language around the relevance of law to HIV, saying law prohibits or permits specific behaviors, and in so doing, it shapes politics, economics, and society. The law can be a human good that makes a material difference in people's lives. It is therefore not surprising the law has the power to bridge the gap between vulnerability and resilience to HIV, right? So they're basically highlighting how the law can be an additional tool in HIV responses to protect against new infections. And there's been some modeling work, this was done out of London, that shows very clearly how much this matters. So if we see over here, we're looking at the millions of people infected with HIV, and modeling out what that might look like in our current legal and policy environment, where we're seeing a fairly sustained rate of new infections. Or if we could actually improve our legal and policy environment, we could see much greater reduction in new HIV infections if we can create these structural changes. So again, for those people who for epidemiologists focus on the numbers of new infections, we can really show how law is important to this. So let's look at some good laws just to make this a little bit more real. We have non-discrimination laws that protect people living with HIV and other populations, such as men who have sex with men, transgender people, from discrimination, those are incredibly useful laws. We also look at inheritance laws. So, for example, in sub-Saharan Africa, it's quite common in some places that if a man dies, his wife is inherited by one of the man's brothers. Right. So if we just imagine for a second that the man died from AIDS-related complications, his wife may also have HIV. She's about to join the brother who may also have other wives, and HIV is going to keep spreading that way. I mean, there's also very many other reasons why we want to stop women being inherited as property, but that's just from an HIV perspective. And also, being able to secure women property rights if her husband dies, so that she's not evicted from the land. So these are the ways that the laws can be protective and help protect against HIV. But the law can also create barriers to accessing HIV services and creating situations in which people are at higher risk. And I mean, this is a really tidy but unfortunate study that happened. It was done in Nigeria in 2014, when literally overnight, same-sex marriage was prohibited. It was prohibited, right? So prior to January 2014, there was some leeway around same-sex marriage, and then suddenly it was totally outlawed. And you can see the significant impact that had on health-seeking behaviors among men who have sex with men. Fear of seeking healthcare, feeling like they have no safe places to go, avoiding seeking healthcare, being verbally harassed, or being blackmailed, right? So the introduction of one law has had these huge negative health impacts among this population. Other laws that we've talked about briefly, criminalization of identities and behaviors, and even things like criminalization of HIV exposure or transmission. And just to say that we still have those laws in this country in some states. And again, very problematic from an HIV perspective, and happy to go into the details of that. So we know now that laws, it's a very powerful tool, but it can be used in really helpful ways and in really problematic ways. So we've got to keep an eye on that. So let's take a step back again to HIV more broadly, and let's see kind of where the world and the UN is right now. In terms of inequalities, the world is committed to the Sustainable Development Goals, they're all designed basically to leave no one behind. That's kind of the mantra of the Sustainable Development Goals. So inequalities is at the heart of that. We also saw in 2021 member states committing to urgent and transformative action to end the social, economic, racial, and gender inequalities, restrictive and discriminatory laws, policies, and practices, stigma and multiple and intersecting forms of discrimination, including based on HIV status and human rights violations that perpetuate the global AIDS epidemic. So again, huge global commitment to challenging a lot of these structural factors that we've been talking about. And just say the current World AIDS Strategy by UNAIDS is titled End Inequalities, End AIDS. So there's a real global focus on why all of this matters. So we've been doing some work to support learning from this. So we have done a lot of evaluation of work to improve HIV-related legal environments, particularly in sub-Saharan Africa. For example, looking at in Botswana, there was recently a court case, 4 years ago, I want to say, a court case about decriminalizing sex between men. And the court case was successful, and this was seen as a wonderful thing. And then about 18 months later, the same case was brought in Kenya, which had the same old colonial law that criminalized sex between men, and the case was not successful. So we've been looking at why was that? What are the differences in the approaches to addressing this legal barrier, and how might you think about that for the future in Kenya? So really trying to dig in very practically to what it takes to strengthen legal environments. And then recently, I'm just going to focus on the last bullet here. We've designed a framework and toolkit for UNAIDS, for their staff and partners globally, to understand and address HIV-related inequalities. And I'm going to spend a little minute talking about that because it's such a global focus right now. So essentially what we did was we set out this framework for understanding HIV-related inequalities and then a process for addressing them. So we were really asking these questions of who's being left behind, why, what's being done to try and address this, and how do we build on that? And really getting people to dig into data. So we've already talked about the fact that in sub-Saharan Africa, most new infections are among women. But if you look at that figure, which I took from our guide, it's not just that it's among women, but if you break that down, in this case, we're seeing that it's much more among younger women. And even amongst the younger women, it's much more about among urban women than rural women, right? So this is a fictional example, but it shows the importance of granularity of data in really understanding who's being affected. And so then we looked at what you have to do about it. And this kind of diagram, I'm sure, will be familiar to many of you. Most people at this point recognize the importance of health inequalities, but actually how you understand them and how you address them in any given setting is a much harder ask. And one of the challenges with working with the UN is you're doing something at the global level that has to work for everywhere. So we don't get hugely into specificities, but what we did want to do was put the individual in the middle and look at these layers, sort of building outwards towards the different drivers of these inequalities, right? So whether we're starting with individual characteristics or actions, so people's individual behaviors even, are shaped by the health systems and services to which they have access, which in turn are shaped by these social and structural drivers such as politics, culture, education, violence, conflict. And to understand that to address inequalities, the only reason that we want to focus on the individual is to understand who they are and why they're being left behind. But to actually do something about it is we need to get to those bigger drivers. So where we're going to have impact is addressing the social and structural drivers and the health systems and services that exist to serve these people. So what have we learned from all of this? We've learned that a biomedical toolkit alone is not enough to defeat a pandemic, right? We know that we have that now, but that we have to get those social and social and structural drivers that we just looked at in the diagram in the previous slide. And that the legal and policy environment is a really important part of this. And we can look at changing legal barriers or supporting implementation of good laws. So, you know, I feel like there's a lot of good lessons in there. And these were all learnt prior to COVID. So let's just point that out for a start. So let's move on to COVID and see how we did with all of those lessons in mind. So again, everybody knows COVID is a coronavirus. It emerged in 2019. And the immediate rhetoric was that the world was in this together, right? We were all talking about solidarity. But the reality is that we weren't. Each country was in this for themselves. And, you know, there are very understandable reasons for that, which we can talk about, but it's also a pretty problematic situation. And now we have good diagnostics, we have good prevention interventions, we have reasonable treatments if we live in the right places and in the right conditions, right? So I want to take us back to the prevention measures that were first introduced in spring of 2020 here, right? These measures were designed by the rich for the rich, right? I sat actually at this very table on this very laptop and continued my work fairly uninterrupted. I taught my classes, I did my research, I had my meetings, right? What a position of privilege. There were people here in LA, the essential workers, the people who live day to day and need to be out there working money, the people who don't have home internet, the people whose jobs can't be done sitting at a desk, who couldn't do that, right? So we already see that within LA, we were all aware there were huge inequalities, right? And now let's think about that from a low-income country perspective, where often 60 or 70% of the population works in the informal economy. That means they buy their dinner based on what they take home that evening. So if they're not out working, they can't feed their family. There was no way that they could stay at home waiting for this to pass. Many don't have access to water or soap, so even hand washing was a challenge. Living conditions are so overcrowded, so even social distancing was impossible for many. So there was this incredible rhetoric, but it was not matched by a lived experience of solidarity, either locally or globally. So I wanted to look at both of those levels. So I pulled some mortality data from the US. And again, you can see like each of the different lines along these graphs represents a different race, ethnicity. And something that's fascinating to me is that this first peak here that you see, the first peak of the pandemic happened amongst the white non-Hispanic population. And then as soon as we had the ideas of lockdowns and all of that went into effect, infection rates amongst white non-Hispanics dropped and stayed lower than other ethnicities pretty much throughout the pandemic, right? Whereas we see different peaks among other race ethnicities. We see the American Indian, Alaska Native peak that happened here. We see a peak among Hispanics that happened later. In fact, they had quite a few peaks. And again, we were looking at why is this? Well, we have to think about what are the race ethnicities of our essential workers? What are the living conditions among different race ethnicities? You know, it's the axes of privilege that we see across every part of our society is reflected in this chart, right? And we see this not only at the national level, we see it also globally. So pretty soon, although it didn't feel like it at the time, we did get vaccines. And by that, I mean, we got vaccines, right? If we look at the map here of Africa, we can see how few people are fully vaccinated even now, right? So while we were hoarding vaccines and we ended up destroying hundreds of millions of doses of COVID vaccines between the US, Canada, the UK, Europe, many, many countries were going without. And many, many countries are still going without because we still have challenges around intellectual property that is protecting the patent on these vaccines, many of which were funded with public funding, right? So we can't exclude corporate greed from our equation of what's driving inequalities. And we can't exonerate governments from the protections that they put in place for those corporations. Right. So again, we're getting into really high level reasons for why some of these inequalities exist. So again, let's look at some of the social reasons of inequalities around COVID. We've talked about some, and I think, you know, most of these will be fairly familiar to us because most of us have much closer experience to COVID than to HIV. But you can see all of these different reasons why those inequalities existed that have nothing to do with biology and everything to do with social factors in our societies, right? And this is just a quote that I actually pulled off Twitter pretty early on in the pandemic. And this is from a doctor in India who says social distancing is a privilege. It means you live in a large house, large enough to practice it. Hand washing is a privilege too. It means you have access to running water. Hand sanitizers are a privilege. It means you have money to buy them. Lockdowns are a privilege. It means you can afford to be at home. A disease spread by the rich as they flew around the globe will now kill millions of the poor, right? Which is a pretty sobering perspective. And I put there a picture of slum area, actually in India, just to give an idea of what some of these living conditions look like, and think about that in terms of overcrowdedness and access to water and sanitation. So again, we can see why we have disproportionate impact. Also, in terms of legal responses, there was a knee-jerk reaction where immediately South Africa introduced a law saying that exposure of someone to COVID-19 could result in prosecution for attempted murder or murder. Romania similarly put a 15-year prison sentence on those who didn't follow the restrictions and therefore potentially caused death amongst other people. And way too reminiscent of Nazi Germany, India was putting hand stamps on anyone who should be in quarantine so that they could be identified if they broke quarantine, and then they could be arrested, right? So fairly terrifying situations going on. And just to point out, COVID is an airborne pandemic that spreads in overcrowded conditions. All of these responses here lead to people being incarcerated. Prisons are like the ultimate tinderbox for COVID. So there's no public health logic underlying this, just a real fear among legislators and politicians. And then we have to look at how law is enforced during a time of a pandemic. This picture is from Kenya, where the police rounded up people who they thought weren't going to get home in time for the curfew. There was a curfew of 7 p.m. And these people they thought were too far away from home to make that. So they rounded them up, they put them in small police vans and then put them in small police cells. Again, not helpful from an epidemiological perspective. The police aren't the right people to be enforcing these kinds of rules. And we saw that the world over. So again, we did a lot of work to kind of support COVID responses globally and nationally. Some of that was helping the WHO with rights-based guidance. Some of it was helping organizations push back against these kinds of laws that seem so detrimental. And part of it was research, looking at who was being most affected, not only by the pandemic, but by government responses to the pandemic, and really figuring out what does that mean for future epidemics that we're in. And I'm just, in the interest of time, not going to go into that in too much detail. But we learned some more lessons from COVID that I think are fairly apt. Again, good medicine's critical, but it's not enough. We need immediate and sustained investment in pandemic preparedness and public health and social security systems, right? We saw that those who are financially disadvantaged were incredibly impacted. And so we need to know who they are so we can reach them with support if we need to. We did that here, right? We did it in California, in the US. It took a little while. But in countries like Kenya and Uganda, they don't know who their population is, where they are, who's disadvantaged, or how to reach them, right? So there's a whole load of work that really needs to be done, and it needs to be started now, because you can't suddenly do this when the next pandemic comes, and it will come, but we need to invest up front. And we need to get to these root causes that I've talked about, social and structural. And to me, the right to health is a very useful framework for doing that, because it's very explicit about these underlying determinants of health. And we also need better governance systems. So I'll talk about those in a minute, but I just wanted to say a little bit more about human rights first, and why I think they're so useful in these situations. So, you know, human rights grew out of World War II. They grew out of crisis and a recognition that we needed to avoid similar atrocities recurring, and that we needed some basic rules that applied to everyone everywhere. And while they're voluntary commitments, every country around the world has made some of these. And so we have an international legal framework within which we're all meant to be operating. And somehow that can be comforting and provide a framework for action at the time of crisis. But on a really powerful level for me, human rights challenge the distribution of power because they value everyone equally, right? So we really need to ask these difficult questions of, why are we here? what's the backdrop to this public health emergency? What's wrong with our systems that inequality is as massive and as entrenched as it is? And how do we address this challenge in ways that reduce rather than foster inequalities? And how do we hold our governments account to this? So these are really different questions than you're hearing about how do we ensure that we have sufficient PPE for our health workers for the next pandemic? How do we ensure that we can develop vaccines quickly? How do we ensure that we have good diagnostics? All of that's important, like without a doubt, but none of that gets to the power asymmetries that are driving the inequalities that will continue to persist, even if we do have those diagnostics and vaccines available to us. So I'm rapidly running out of time, but I just wanted to say a little bit about sexual and reproductive health, because I think everybody's aware that we're in a time of retrogression in this country and in many others. The maps and figure here are about abortion, and we can see where abortion is very restricted. We can see that there have been 58 new restrictions enacted in this year alone in this country around abortion. There are currently 501 anti-LGBTQ bills in the US. There's been over 100 bills attacking trans people in the last 3 years. And we're also seeing attacks emerging on the abortion pill and on contraception more broadly, right? So we've got the same thing. We have populations or behaviors that are othered, that are marginalized, that are looked down on by a certain powerful elite, and they are being further oppressed by changes in our legal environment, right? But it's not all bad news. There's a lot we can learn from other countries. Across Latin America in the last few years, we've seen what's called the Green Wave, this sort of social movement, helping liberalize abortion laws and increasing access to safe abortion for millions of women. We've seen lots of countries decriminalizing sex between men in the past few years, and we're seeing laws that protect transgender health being introduced and legal barriers being repealed. Most recently in Japan, I think it was 2 or 3 days ago, they repealed a law that required trans people to be sterilized if they wanted to officially change their gender. And that has now been repealed, which obviously is a huge advance. So again, we at the Institute, we've doing all sorts of work around this. It's kind of our bread and butter. I'm not going to get into it, but I just want to really highlight that there is a lot that can be done. And again, if we're tying research into what's happening in our current legal and policy environment, we can really inform immediate change. And that's something that's very exciting about our work. So lessons learned around this: sexual and reproductive health and rights are politically very sensitive, and politicians want to be re-elected. That makes them hard to deal with, right? But we are central, we the public are central to changing laws and policies, both for good and for bad. And we see that in this country right now, right? Huge social mobilization, but very divided. We can't ever take for granted our legal protections. We shouldn't. They're fragile. They can change all the time. And it's a tough job to take on these difficult topics, but we have to, because it's about people's lives. And so I just wanted to recenter people before finishing. It's us as people, we have to challenge the structures of oppression that continue to divide our world. We, the privileged in this equation, have to give up power to create space for those to take it. And we have to vote wisely. We choose our politicians. And so it's a huge step to me in terms of addressing inequalities, is thinking about voter education. And again, remembering these aren't just numbers, it's people whose lives are at stake. So here we have our health, including inequalities, being shaped by all these macro environments in which we live. But rather than blame the people who suffer from these health inequalities, we need to really ask ourselves, what is our role in the structures that have created and now perpetuate these inequalities? And what can we do to challenge these existing power symmetries? And USC is so ideally situated to take this on. It's a huge interdisciplinary challenge, but we have incredible intellectual might across our university. We have a position of privilege, and therefore I think we have a responsibility to leverage that and try and address some of these, what Michael Quick, then provost, would have called wicked problems. So I will stop there. Sorry, I ran on a little bit longer than I had planned to, but thank you very much, and I'm super open to any questions if you have them.
Thank you so much, Laura. We do appreciate it. Do I see any hands raised or? Okay, Mimi,
Yeah,
please.
it's a question born out of ignorance. So we definitely there are a lot we can do, put in place as policy, as whatever protocols for the next epidemic. But I wonder, Laura, is there a commission, a study group or whatever at the federal level to actually take this impending, as you said, it will come, take this seriously? And then, but most important, I have become a super fan of yours. Is USC specifically, our institute, and you having a seat at the table if such a thing has already been organized?
Well, thanks very much, Mimi. And it's a great question. There's a lot of different groups who are working towards this at the national and global level. So, for example, at the global level, there's a pandemic treaty that's being negotiated, and we have had inputs into some of those drafts. And there's a huge gulf between what we would like to see in those drafts and what we actually do see, because countries need to all come together and agree on that content. So I've been more engaged at the global level and sort of trying to figure out, how do we think about our entire global governance system and how that needs to be shaken up and strengthened, and with better representation from the global south, because right now we have voices protecting the pharmaceutical industry in those discussions, basically, and that's really problematic. Within the US, it's slightly easier because we have a pharmaceutical industry that we can harness. But I'm going to say, like, the resources are still going to that, to building the medical preparedness rather than the public health preparedness. My colleague Sophia's on a group that talks about this a little bit, but it's not the only one. But we're very much engaged wherever we can be in those spaces, and trying to bring the attention to these social and structural factors at every level. As I say, we work with the mayor's office at the city level, we work with the county, we work at the state level and the federal level. And I think there's a need for action in all of those different spaces.
I have a question. In today's world with social media, there's a lot of pushback, and there's a lot of conspiracy theories, and a lot of people don't believe in what our health systems are promoting.
Yeah.
So how do you combat that in your work?
That is an excellent question, and it's a huge challenge. It's a huge challenge everywhere. People have lost trust in the medical establishment, in the scientific community, and in politicians in general. And honestly, that's not something that you build back overnight. There are many sort of long-held historical reasons why that mistrust exists in many places. And I think we need to own it, and we need to speak to it rather than pretend it's not there. And this is long-term community engagement work. It's engagement with our local communities, it's engagement with our student communities, and really teaching them about critical analysis of information and how do we think about how we trust or don't trust different information sources that cross our desks. It's talking to medical professionals, it's talking to policymakers, and recognizing that, again, across the whole chain, this is something that we need to talk about. And it's a bit like any historical injustice. If we don't admit to it and put it out there and understand where it's coming from and talk to people about what they need to regain that trust or to recreate it, I don't think it just happens. And it was a huge problem in the pandemic, partly because of social media, but partly because every country had a top-down response. And so these laws were being imposed that people just couldn't comply with. And so then they were just mad about the whole thing and wanted to resist any messaging coming from government because they felt misunderstood. And so community participation in mechanisms for pandemic preparedness and response, I think, is a really critical part of this. And again, it's going to take time. We don't want to wait until the next one hits to start thinking about how to do this.
Thank you.
So, Laura, I was struck by the quote that you had of the Indian individual who talked about all of these different levels of essentially minimums, right? You know, all things being equal, if everybody has access to all of those resources, then we can really focus around some of the things associated with maybe particular types of events, such as the sexual health and also pandemics. But it strikes me that there's still this tension between those countries that are devoting resources to be able to provide the very basic things that folks need, such as safe water, such as space to be able to be really cared for in an appropriate way. Do you have a sense about how those priorities are being handled in a global sense? And I realize that might be an unfair question because you got all types of different responses around countries, but are the resources starting to be met around some of what I think to be minimal structures that are going to make public health better?
That's a great question, Mike. And I think, I mean, clearly I'm not going to have a full answer to it, but I think there are a few factors that play in. I think we need to look very closely at what the international community is funding in terms of global health. And it, it goes with trends. And the trends don't always match the disease burden or the basic needs. And we see disproportionate funding for example, HIV, TB, malaria, and we see far less for things like safe water, diarrhea, pneumonia. So there's definitely a responsibility, I think, of the international community there, because so many low-income countries are so dependent on external funding to help meet priorities. That doesn't exonerate local governments. Like every government should be, I mean, African governments are committed to putting 15% of GDP towards health. None of them do that, right? Because resources are scarce. And again, people like visible projects. So, a big shiny hospital looks really good if you want more votes next election, right? But putting taps in people's houses is way less visible, far more impactful for many communities. But again, we need to come back to sort of what are the political motivations that underlie these decisions, both globally and locally. We see huge waste, huge inefficiencies in the system, lots of money being lost along the way, which is something else that would be good to look at. So there's not enough money, but it is also not going to the right places for reasons that differ by level. But basically most often have to do with re-electability, whether that's of a donor government like the US government, who have funded so much HIV treatment around the world. It has been transformative, like truly, and they love that because they can count pills and they can count lives, but they're far less interested in gender equality, because how on earth do you measure that over what time? And it's just not as visible to people.
Laura, do you and your colleagues from USC get invited to appear before congressional appropriations committees, such as Foreign Operations Committee in the House, where funding for the United Nations and international programs is decided?
I certainly do not. Sophia, our director, is on the advisory board to PEPFAR, which is the President's Emergency Plan for AIDS Relief, which is, there's billions given through that. And so she has some input into that mechanism. But in terms of just the general funding allocations, no. And as I say, maybe because I started my work outside the US, I've always been more linked in at the global level to the World Health Organization and their priority setting, or the UN Development Program, than the US government. But I would love to get into those spaces and give my 2 cents on how I think we could be doing things better.
Well, now that USC has a national center in Washington, D.C., it might be an opportunity to ask the director of that center to work on getting you access, you and your colleagues.
We are certainly working on that right now.
Good.
Great thought.
How about the World Health Organization? What kind of a role are they playing? I know that our former president tried to get us out of that, and our current president put us back in. But in terms of some of these global strategies and policy changes, what can we attribute to their work?
I have huge respect for the World Health Organization to start with. I think that it is so grossly underfunded, and the demands on it as an organization are phenomenal. I mean, they were even before COVID, but since, they're really being asked to do everything, but on an absolute shoestring. And there's definitely imperfections within the organization. There are problems in every organization, but technically they are incredibly strong, incredibly solid. I think the communications work that they did throughout this pandemic was incredible. I don't know if you watch any of their press conferences, but they were doing daily press conferences for months, maybe more than a year, that were just simple to understand. It's kind of stuff that I use in class with my undergraduates. So, and they get it. They can hear the messaging. So I think they played an incredibly important role there. I think they're stymied by the system because the WHO can only operate in a country at that country's government's invitation. So when we're looking at the investigation into the origins of COVID, WHO's had very limited access to a lot of the information that would be really useful. And so, we've got a bit of a tension here between state sovereignty and the global good that I don't know how to resolve. But I think that given the operating restrictions, WHO has done an amazing job. And if we would actually fund it to the level required, it would be amazing for the world. I think we're seeing a retreat from multilateralism generally around the world right now, which is scary. But if we could get people re-engaged in a multilateral system, even if that means designing it differently, I think it should be designed differently. But I think we need to put our attention to that rather than walking away from it entirely.
Thank you. Well, I don't see any other hands going up at the moment. But Laura, thank you so very much. You have you've opened my eyes, talked about topics that I hadn't even dreamed of, and I appreciate that. I'm sure all of our guests do. Oh, thank you,
Thank
Mike.
you. Thank you.
Thank you all, and thank you for the invitation to share with you all.
We're very grateful you took the time. Thanks so much.
Bye,
Thank you,
everyone.
Laura.
Bye.
Take care.
Bye.
Bye-bye.